Good evening, everyone. I am Nagraj on behalf of IIP Digital Media Team. Welcome you all to today's webinar organized by IIP and IBWC Chengapattu District, Tamil Nadu on the occasion of Women's Day webinar on women's health. So this webinar will be live on IIP India YouTube channel. Please subscribe and share our all social media platforms for the recent update. Now, without wasting much time, I would like to hand over the session to today's moderator, Dr. Divya ma'am. Over to you, ma'am. Thank you.
Thank you so much, sir. Good evening, one and all. I'm Dr. Divya Karthik. Can we start with the session now?
Yes.
We have to wait for someone.
Yeah, you can go ahead, start, Divya. Like it's 7 o'clock.
Thank you, ma'am. Good evening again. Women are not occasions to be celebrated on a particular day. We actually deserve respect and recognition each and every moment. I wish all dear ladies a very happy Women's Day. This is a webinar on women's health organized by the newly formed Chengalpattu district. The coordinators are Dr. Sindhuja ma'am, Dr. Deepa ma'am, and Dr. Vanilla ma'am. All the best for your newly joined team. I take the pleasure in inviting Dr. Sanjeev sir, IIP President, Dr. Ruchi Varshney ma'am, Central Head of IIP Women's Wing, Dr. Mercy Jayaprabha ma'am, South Zonal Head, and Dr. Janani ma'am. Dr. Janani ma'am is our Tamil Nadu State Head of IIP Women's Wing. She's an entrepreneur and director of Evergreen Physiotherapy and Fitness Solutions. With 11 years of clinical experience, she's now pursuing practice on aquatherapy on prenatal and postnatal exercise. Ma'am, I request you to take over the session.
Thank you, Divya. Thank you for the introduction and welcome, team. And this is your first webinar, and I'm so happy to be here and welcome all the delegates here. And thank you for attending the webinar with the short notice of the sessions. So we have two beautiful topics coming up today with two great and eminent speakers with us. So we have Dr. Subhashree ma'am, and she is obstetric specialist, infertility specialty, and laparoscopic surgeon. And we have Dr. Jaishree ma'am, and she's a clinical physiotherapist in OBG. Yes, women's health is like growing wide in physiotherapy, and that's a debatable topic and a discussable topic with more on research dimensions. We have more platform to explore it. So here we have two more topics to explore and gain knowledge. So I hope you have a wonderful evening. Well, I welcome you all on behalf of IIPWC Tamil Nadu, and IIPWC is celebrating Women's Day across India, and we have more topics like sexual health, menstruation, and everything going on. So this is two other topics where Chengalpattu team has brought about to you. So we'll discuss it and gain much of knowledge, and I'll be sharing most of you with the knowledge with you all in this evening. Thank you. So over to you, Divya.
Thank you so much, ma'am, for the wonderful introduction about the speakers. Let's start with our session. So we have two eminent resource persons. Dr. Subhashree ma'am, she's an assistant professor, obstetrics and gynecologist. She's known for her excellence in infertility and laparoscopy. She has been placed a record for best performance in treating patients in 2021 by SRM Hospital. She has presented her papers in international and national conferences, and her ongoing project is based on the publication in postpartum glucose tolerance in GDM mothers at 6 and 12 weeks to discover knowledge of pap smear in health workers under her institution. We welcome her. on this wonderful session.
Yeah, we don't have them as panelists, is it?
I've already informed her that they would be getting a separate link for that, separate mail for that has to be used.
Okay, but I'm not able to see them because they won't be able to talk actually. So I'll just come. Sir, can you, add those two people like Dr. Jaishree, Subhashree ma'am and Jaishree ma'am as the panelist here, please? Divya or Sindhu, can you forward the mail IDs to Dr. Nagaraj, sir? Yeah, she's here. She's here. Yeah. Thank you, sir. Thank you so much. Welcome, ma'am.
Thank you.
Thank
You're
you.
able
Sir. Yes, ma'am. Absolutely. Can you talk again?
Hello.
Yes, ma'am. Yes, ma'am. We are able to hear you. Perfect. Thank you.
Good evening, Dr. Subhashree ma'am.
Good evening, Da.
It's good to have you here.
Yeah, it was a very warm welcoming. Thank you so much.
It's a pleasure, ma'am. Can we go on to the session? Can we share the screen?
Okay. I have chosen the topic on cervical cancer and breast cancer. Happy Women's Day to all.
Sorry, ma'am. I'll just do it again. Please, ma'am. Thank you.
Okay. I'll start the session. Happy Women's Day to all. I just follow this session by telling my quote, protect your daughter and educate your son. Please don't protect your daughter. It's better to educate your son to how to deal with a daughter or wife and a mother. My topic is breast and cervical cancer awareness and HPV vaccination. How to live a healthy life. For a woman, there are two important things and changes in a body, that is breast and cervix, which everybody will never follow it. So in India, it is the many women are dying of two cancers. One is breast, the other one is cancer cervix. So we take an oath like I am and I will. By this session, I think everybody will follow these. The burden of the disease and the leading causes of death among female worldwide is cardiovascular diseases and malignant neoplasm. If you see, the second line is malignant neoplasms. So every woman has to take care of two things, cardiovascular system and her malignant issue. The other infections follows these. Worldwide in women, breast is the first and cervical cancer is the fourth most common of all cancers. So how do we live a lifestyle to avoid both cervical cancer and a woman and a breast cancer in a woman? So by this session, you will come to know how and what you want to do and how you follow your body changes. The incidence of cervical cancer is compared to other cancers in women in all ages. See, you can see the link. The breast cancer and cervical cancer are the most. Breast cancer is 23.8% and cervix cancer is 20.2%. The breast cancer is topmost fatal disease in India. Cancer cervix is the most common cancer. Only 12.5% earlier is localized stage. 70% is present in the advanced stage. So what they tell is cervical cancer can be avoided if you follow some criteria. How do you know that cervical cancer is occurring in you or the changes in your body? The normal white discharge should be taken as consideration after the reproductive age group. Incidence of gynecological cancers in the world. If you see, it is more is cervical cancer, ovarian and uterine cancers. But the cervical cancer is the most common cancer. In India, cancer cervix tops the important and followed by ovarian cancer and endometrial cancer. Cervical cancer is very common because of low socioeconomic status in India. India accounts for 1/4 of cervical cancer cases and deaths worldwide. We can avoid the cervical cancer by following one injection that is known as HPV injections. Nearly 90% of women who die from cervical cancer have poor access to prevention, screening, and treatment. Yes, you can avoid cervical cancer if you are vaccinated. This is the places of cervical screening which is missed and where all the cervical cancer screening is taking place. If you see, it is very less in Karnataka, Tamil Nadu. This is a normal uterus, vagina, cervix, and fallopian tube. So the cervical cancer is nothing but the cervical canal. You can see the picture where the cervix is there. The cancer which occurs in the cervix is known as cervical cancer. 13% is less than 35 years, and in 35 to 44 years, it is 52%, and in 45 to 54 years, it is 65%. So you can see from 35 till 75, anybody can get this cervical cancer, and it is totally preventable if you follow just a vaccination called HPV vaccination, which is available in India, but people are not knowing how to use and are scared of using a vaccine. What is the risk for cervical cancer? The risk is sexual practice, infection, poor hygiene, early age at first coitus, family history, smoking, multiparity, old age, any contraception used like copper T or any barrier method, genetics, nulliparity. Some causes are unknown. That is just 11%. Cervical cancer is sexually transmitted disease because of HPV virus. HPV is the primary cause for cervical cancers. Some strains of HPV have a predilection to genital tracts and it transmits through sexual contacts. HPV is the most common virus that affects and infects the teens and adults. It doesn't mean multiple sexual partners. It means one sexual partner also can get this HPV infection. HPV is nothing but human papilloma virus. HPV virus is the most common virus that is spread through sexual activity. HPV can cause the growth of abnormal cells on a woman's cervix. If left untreated, these abnormal cells can develop into cervical cancer. Normally, every girl will have this HPV infection. If you don't treat it, it will become a cervical cancer. The nature of this HPV is initially there will be an infection, and if there is persistent infection, it is called CIN. It can be cleared by some tablets and antibiotics. But CIN 2 or 3 will lead to cervical cancer. So you have to do the screening from CIN 1. The primary prevention. How do you prevent the cervical cancer? By national development, health education, healthy lifestyle, avoid high-risk sexual behavior, HPV vaccination. Okay, please teach a woman how to prevent this by not wearing a tight undergarment or not using perfumes or dyes in vulvar region. Also educate her about the barrier method, birth contraceptive pills. Discuss potential changes in sexuality if radical surgery is needed. Encourage her to communicate openly with her partner, refer her to appropriate community resources. Nothing, but you have to speak openly to your daughters or sisters, even parents. Sometimes daughter will become a parent to her mother. So it is like you have to teach your mother, sister, or daughter after the session to not wear a tight garment and to not use any perfumes in her vagina or vulva. Secondary prevention. Okay, you have got an HPV infection or not. How do you know this? You can do a pap smear. You do a pap smear this year. Next, repeat only after 3 years if there is no infection. You have done it for 3 years and there is no infection, then do it 5 years once. Once you have done 3 times, 3 years once, then no need to get screened at all. So a pap smear is done every 3 years once. Indian scenario, population-based screening by pap smear is not at all feasible. Visual inspection of the cervix, low specificity. Prevalence of HPV infection is 8 to 10%. If HPV is used as primary screening, need for pap test decreases. If all women have taken her HPV vaccination, then don't need to do a pap smear. HPV testing has a higher sensitivity and lower specificity. Yes, cervical cancer can be prevented by following one vaccination that is called HPV vaccination. Okay, these HPV viruses are, how many HPV viruses are available? There are many types of HPV viruses which is there. Malignancy worldwide, and 84.1% of cancers in India is common by HPV virus. If 100% efficacy against HPV 16 to 18 can reduce the cancer burden by 80%. These are the types of vaccine which is available, that is Cervarix, Gardasil, Gardasil 9. It can be used in both males and females except Cervarix. Who is the targeted population? Okay, whom all I can give this vaccination? It is mostly given in females from 9 to 45 years. The best time when to give a HPV vaccination is before her first sexual activity. Most effective before sexual debut. WHO recommends routine vaccination of girls from 9 to 13 years. In India, IFP recommends administration from 10 to 14 years. According to Foxy, it is 10 to 18 years, and vaccination in older women is always a dilemma. Dose schedule, there are 3 types of vaccination actually. It is quadrivalent and bivalent, which is available in India. Quadrivalent, you give 0, 2, and 6 months. Bivalent is 0, 1, and 6 months. During pregnancy and lactation, we are not supposed to give this HPV vaccination. What are the safety, side effects, and precaution? Larger trials and Patrica and Future are proved safe. Injection site reaction and syncope. No increase in new onset chronic disease or autoimmune disease till date. No effect on sexual behavior till date. Contraindication, severe allergy to first vaccination dose. In pregnancy and in breastfeeding, we are just avoiding it. How does acquired immunity after HPV vaccination is compared with natural infection? It is partial immunity against identical genotypes, but by vaccination, it is 100% immunity, and the study have shown that there is 100% immunity. In pregnancy and breastfeeding, we don't give HPV vaccination at all, but in lactation, quadrivalent HPV vaccination is licensed, but we are not following it here. Facts about human papilloma virus vaccine is the vaccine is very safe. It cannot cause any bad effects. Vaccine does not have any fertility problem. It does not contain any harmful ingredients. Getting a HPV vaccine is not opening the door to having sex. The HPV vaccine is for both males and females. HPV vaccine works and can help to prevent cervical cancer. HPV vaccine lasts for a long time and maybe forever. See, this is how a girl's HPV vaccination is there. Everybody can get HPV infection, but low grade and high grade are there. The low grade after some days can change into cervical cancer, and a high grade abnormality can change by 10 to 15 years. So you have to get vaccinated. It will be a screening method is pap smear method, and by giving a HPV vaccination, you can get 100% immunity. Six reasons to get an HPV vaccine for your child. You will be preventing HPV infection, and 6 out of 10 parents are choosing to get the HPV vaccination for their children. By giving vaccination, what are the common problems parents are thinking is HPV isn't that common. HPV can cause only can cause cervical cancer. HPV vaccine isn't effective. HPV vaccine is just for women. You only need the HPV vaccine if you are sexually active. It's all a myth. HPV vaccine can get by anyhow to your daughter or sister. So HPV vaccination can prevent this HPV infection. Stop HPV and protect your future by giving a vaccination. This is 2030's target is now we are 90%. Now 70% are screened and 30% reduction in mortality from cervical cancer. But we want to prevent totally this cervical cancer at 2030. Every woman is screened by 40. Every girl should be vaccinated by 14. This should be today's oath. Next, we are coming up to a topic called mammogram. Women above 40 or older should have a mammogram done every 1 to 2 years, depending on the risk for breast cancer. Consult your health provider if you have a family history of breast cancer. 20s and 30s breast examination is needed every 3 years, and 40s and over every year it will be better to have a breast examination. Between 10 to 15% of breast lumps are not visible on standard mammogram. Risk factors for breast cancer is first of all being a woman, cigarette smoking, obesity, never having a child, family history, and ethnicity. This is how you examine your breast. You have to find where the lump is, what is the lump, whether it is mobile, non-mobile, whether you're able to move the lump or not. Then if you find a lump, just meet your family doctor or a health provider. This is the way you have to palpate a lump. Just touch, see how much big size it, whether it is a groundnut size or a lemon size, whether it is painful, whether you are getting any discharge from the nipple. Okay, the symptoms which is there in the breast cancer is there will be change in color of the nipple, there will be pain, skin dimpling, there will be a breast lump, blood stain discharge from the nipple, and changes in the skin color. This is how the nipple will have bloody discharge. This is a purely orange changes which is noted in the breast. You can see the nipple which is inverted and which has gone inside. It looks like an orange, dimple shaped orange. Thank you. Thank you so much.
Thank you so much, ma'am. It was really a wonderful presentation.
If anybody wants me to explain in Tamil,
you can share some words in Tamil also, ma'am.
anybody have any questions?
Can I hear Dr. Subhashree?
Yes, yes. please.
Yes. So there have been statements like menstrual products has an influence on cervical cancer. Can I have your inputs on that?
Yes, ma'am. I didn't get you.
Menstrual products, disposable menstrual products, has its impact.
Okay. See, usually there are a lot of menstrual products which is available, like tampons, menstrual pads, anything which is hygienic can be used. Nowadays, menstrual cup is also available, which is a newer type, and it is very helpful for both teens and married women and reproductive age group. Menstrual cup is the newer thing which has come to our market. It's good. You can follow menstrual cup. There are sizes according to which you want, small, medium, and large. You can use whichever is comfortable for you.
Yeah, thank you. Actually, I was asking whether these disposable menstrual products has an impact over cervical cancer.
No. There is no disposable pads which causes cervical cancer. It is totally by your HPV infection only. First is your HPV infection.
Okay, thank you. Thank you so much.
Yeah, participants, any other questions?
I have got a question actually.
It's a menstrual. Yeah, I'll just read it.
What is the question?
Yes, shall I continue? Ma'am, is that a question? Is that
No, I'm not able to hear you.
Ma'am, Subhashree, ma'am, the
Yes.
question is that menstrual cup is good or it leads to any other complications like cancer because if there is any regurgitation.
No, the menstrual cup doesn't cause any cancer and is very safe. Only thing is, and very economic. People in villages can't, there are so many people even today who can't buy pad. So you can give them a menstrual cup. Government is going to provide them a menstrual cup which they can use hygienically. A menstrual cup is very safe, and if you keep it clean, you have to keep it hygienic, and there is no menstrual cup which can cause cancer or any other cancer.
Okay, ma'am. And another question is that someone said it leads to endometriosis.
No. Endometriosis is totally a different subject. Endometriosis is not caused by menstrual cup. You don't have to worry at all.
And another one thing is that cause of HPV is getting infected.
No. If you are having a HPV infection already, and if you're using a menstrual cup also, you won't get cervical cancer because of that menstrual cup.
Okay, ma'am. And another one question, what about using tampons?
Again, tampon. Tampon is also a method for your menstrual blood to flow. Because of tampons, you don't get a HPV virus infected. It is because of your hygienic and if your sexual activity, and if your partner has HPV infection, then you may get a HPV virus for your cervix. It is nothing behind your pad or tampons which is causing this infection.
Participants, any other questions?
Again, to prevent the cervical cancer, I will just take like a take-home message. I'll tell you in the how to find out a HPV is there in a male or a female. Okay, I got one question. See, HPV vaccine, to know that you are affected by HPV virus or not, you have to undergo a test called pap smear test. By doing a pap smear test or a vaginal swab, you will come to know whether you are having an HPV infection or not. Mostly it is done 3 years once. Your sperm analysis also can give, and males also will have some discharge, painful, and their penis will be infected. You can ask them, and you can send their swab for testing, and you'll come to know whether they are infected by HPV or not.
Participants, any other questions? Thanks a lot for your response, ma'am.
Is there any duration for vaccination, ma'am? There are HPV vaccine is given, like there are two types of injection. I told you in my slide. It is Cervarix and Gardasil. Both are good, but Gardasil is better because it is used 0, 2, and 6 months. So first vaccine, if it is today, you use the second dose 2 months later, and the third dose will be 6 months later. And the best time when to give the injection is once the person has attained her menarche. After 1 year of her menarche can be given. Before your first sexual intercourse, if you take the HPV vaccine, it is 100% better. And you will have immunity towards the disease 100%.
Any other questions, participants? You can use the chat box. Thank you so much. Can we move on to the next presentation, ma'am? It was a great pleasure to have you here in this platform. It is actually a must topic for Women's Day celebration.
Thank you. Thank you so much.
Participants, any other questions?
Hi, ma'am. Good evening.
Good evening, Das.
Okay, ma'am. I have a question.
Yes.
Whether above 25, if they get vaccinated, is that effective, ma'am?
Yes, it is totally effective. But before getting the vaccination, please do a pap smear test.
Okay, it's a must.
Yes, doing a pap smear is better so that you will know whether you have acquired the infection already. If it is low grade, you can still go for vaccination, because I had shown you in my slide, low grade or high grade cells, it will take 10 to 15 years to change a cervical cancer. So better if you get vaccinated by that period also. But first you do a pap smear if you're already sexually contacted.
Actually, after the postpartum period, we can take vaccinated. When we can take the vaccine, ma'am? Like after 1 year?
Postpartum, yes, better you after you stop feeding. Once you stop feeding, you can go for vaccination.
After the pap smear test, right, ma'am?
No, for postpartum, don't need a pap smear. Once you stop your feeding, you can go for vaccination.
Okay. Okay, thank you, ma'am.
Thank you. Thank you.
Thanks again, ma'am. So let's move on to the next presentation.
Yeah, sorry, I had a network issue and I could not able to connect that. And another one thing, Divya, many participants are in the waiting list. Can you please join them? A few of them are in the
Yeah, I'll just try now.
Vanilla, trying to take over this question and answer question.
Ma'am, not audible.
Yeah, I'm not audible actually.
Audible?
I didn't get the question. Is there any question?
No, ma'am.
No, ma'am.
Okay.
Thank you so much.
Thank you.
So our next speaker, Dr. Jaishree. Dr. Jaishree Jaikrishnan, ma'am. She's a clinical physiotherapist in obstetrics and gynecology for the past 17 years. She's a founder and director of Happy Mom Healthcare. Am I audible? Yeah, okay. So she's the founder and director of Happy Mom Healthcare, collaborated with private hospitals in Chennai. She's a pioneer natural and water birth therapist in Tamil Nadu, introduced aquanatal concept in Chennai, connecting birthing and lactation workshops and conferences, foremost international board certified lactation consultant in Tamil Nadu, and served as an examination committee member for IBLCE. She's an advisory member for I Decide Breastfeeding Promotion Network of India, initiated nationally first private hospital in breastfeeding friendly hospital initiative. She has presented scientific papers in international journal Lancet and national obtained journals. We welcome you, ma'am. It's good to have you here.
Thank you, Dr. Divya. I thought you'll choose one or two from that. I never thought that you'll read all. That's quite an elaborate.
Great thing about you to share actually in this platform.
I thought
great job actually.
So that is quite time consuming, no? We have to watch all the time.
Yeah, we'll start with the session.
Yeah. I need to thank IAP WC team. I'm very, very happy to be a part of the team because for last so many years, I've been not so much active in a physio team. I'm very glad to be actively to this team, and I need to thank IAP President Sanjuja and our WC head Dr. Subhashree, and I need to say Dr. Janini, she's been so sparkling to take all the things into action. As more of our Tamil Nadu crowd is here, I feel I can combine the language, both Tamil and English, so it will be comfortable for everyone who listens. Okay. So Dr. Divya, you'll be just moving over the slides, right? Okay, so going with the next slide. Today's topic is about role of postpartum physio, which is actually a very wide aspect being seen in all maternity setup. Currently, I'm seeing there's a lot of demand. And in my organization, Happy Mom, been working in relation to pregnancy, labor, and postpartum from 2009 onwards. My organization came. Before that, I was practicing on my own. So to go ahead with postpartum, what is postpartum or postnatal period meant to be? It is just immediately after childbirth, where your body, including the hormone level and uterus size, which comes to your non-pregnant state, that is before your pregnant state, it comes back to shape. It's said to be a postpartum. So this postpartum period, we tend to term as puerperium, puerperal period, or immediate postpartum period. The earlier one. Are commonly used only for the first 6 weeks post childbirth. So the first 6 weeks only we said has to be a postpartum period. Yes. So next one. Due to a pregnancy and labor and childbirth, there have been a lot of changes women body goes through. So this changes continues post childbirth also. So that continuation takes its own time to regain its own normalcy. So, if a puerperium period period of time where maternal physiology or own physiology function, which comes back to the pre-pregnancy time, just a puerperium period. Uterine involution, which is the third stage of labor. Uterine involate once after placenta expulsion, whether the uterus has contracted, they check onto it. But generally, it takes nearly 6 weeks time also to get to be completely involuted. To that level, the mother needs to be followed up. And perineum care, which mother goes through a normal vaginal birth or a natural birth, it's actually painful for her in the perineal region, which may take to 1 week, 3 weeks. Sometimes it goes beyond that also, depending upon the grade of TAD which they are going through, or if there's any instrumental birth they had. Based on that, the perineal healing will be different. And menstruation, ovulation, again, this differs women to women, it differs. But mostly it's been said, mothers who've been breastfeeding exclusively, sometimes they don't get it for a year also. But some mothers, they tend to menstruate earlier for mothers who are not being exclusively breastfeeding. Of course, there's a changes on breast. Your breast gets different in change, suddenly getting bigger in size and lesser in size. And urinary system, the renal challenges is like during the pregnancy period, there'll be a frequent urination pattern will be there. Then postpartum, the bladder gets filled up, but still they tend to empty the bladder maybe twice in a day or once in a day because of more commitment towards the baby. They'll not have that initiation of going to the restroom. So because of that, there are chances of some people getting urinary tract infection, or the other way, they will not able to like hold on to the urine when they have a cough or sneeze. There's a drops running out. This is all meant to be the post delivery challenges what a mother goes through. And another one is the digestive system. Either they be highly constipated or there'll be an incontinence. This constipation, yes. So this constipation part can be seen immediately postpartum itself, that is during the hospital stay itself they can see. And incontinence issue, generally we tend to see after 3 weeks or 4 weeks after postpartum. When they come for the review, we tend to see that. So these challenges is there. Another main one is hemorrhoids. Due to prolonged second stage of labor, maybe it's for 20 minutes or 30 minutes, or sometimes they've been in the pushing phase for hours together. These things have been gone to hemorrhoids. Sometimes they go with anal fissures also. And pelvic organ prolapse, it comes all together. Your anal area, your rectum, your bladder, and your uterus, everything comes together for the pelvic organ prolapse. So there's a very wide scope as a physio is there to practice in the field of postpartum physio practice. Next one. So postpartum physio, I've divided it to two aspects: immediate postpartum and outpatient. So immediate postpartum, what are the cases we generally tend to see is the normal vaginal birth and natural vaginal birth. What is different meant to be? Normal vaginal birth, they be into this normal lithotomy position. Lithotomy position, what you know, they lie down on the back and legs spread up. That's a normal lithotomy position. Natural vaginal birth will let the mother to deliver the way she wants. She'll be delivered on the floor. She'll be delivered on the cat and camel pose. She'll be delivered in the Vajrasanam pose. Sometimes she'll be lying down on the sideways, anything. And in this both, there's a planned episiotomy will be there for the normal vaginal birth because of the lithotomy position, which we are not sure how far the tag will go post-delivery. And for the natural vaginal birth, it's a natural tear which happens. So based on that, the postpartum care also differs. So instrumental deliveries using the vacuum forceps have been outdated now, and medicinal deliveries like using epidural, like they say as painless deliveries, anesthesia, and they're going with the labor is epidural. Water birth, it's a very new concept. We've been doing water birth from 2015 onwards, still not being recognized by ACOG. It's been said as an experimental birth. So until unless the couples are being prepared to know the pros and cons, and then they go through it. Again, water birth has its own challenges post childbirth, because during the water, with the warmness in the water, they don't know how far they're pushing. They tend to push with the full speed as such. That may have an influence on the perineal part. Again, it differs case to case, and C-section. So IP wise, these are the cases we generally tend to see. Postpartum, all the cases we tend to try to follow up at least for the period of 3 to 6 months post-delivery, try to follow. And later on, they tend to keep in touch with us. I'll just show you how we work it on to it. Yeah, next one. So as I already said in the first thing, the postpartum physio has been important because of lot of changes in the pregnancy. Your muscles goes for weakness. There's a lot of ligament getting loose in elasticity, and your pelvic floor muscles getting weakened. So the scope for each and everything has to be seen and be monitored and should be overviewed on a regular basis, and then only the mother will get to be completely recovered and she'll be prepared for the subsequent childbirth also. So it's not just by saying that she's gone back to shape. It doesn't mean back to shape means she's okay for it. So gone back to shape means to be the internal organs should be completely in its normal functioning level. Yeah, next one. So before starting the IP visit, we've been very clear in to get a medical clearance, whether we can see these clients. I prefer to say them as clients because they are not patients until unless they come up with a problem, yes, but still they are healthy individual who are going through a normal physiological process. So the normal physiological process not required to be a patient for them. According to me, I make them as clients only. So we make sure that we go through the medical history. We know that they are fine to go with the interventions, and then we start going with the assessment protocol. And we do have a pre-existing and prior medical conditions. We go through it, and we do encourage the way they have to move forward ahead. And it's not just only the medical condition. We have to see their psychological aspect, whether they have a prior history, the prior barrier which they had at earlier negative experience, which we have to talk. So more of talking is involved, more of communication is involved. The more you talk, the more you get answers. Not required to be just question answer, like asking, did you have this, did you have that? Not like that. Just on a normal conversation, how many births you had, like that. In a conversation, we tend to pick it up. And we have to plan the exercise interventions by telling them how they'll proceed, what would be the progress, how they can come back to the normalcy, why they have to come back to normalcy, what is the importance in that. So once there's been said in a detailed process, we can see them to turn up in the OPD visits. Yes, next one. So when you take with the postpartum history, of course, you take care of everything, but noting down is actually very challenging, which I usually tend to see in my IP rounds. So we have a team, so we know who will do what work and how we've been progressing forward. And next one, I'll just show our forms. Next one, Madhavya. So these are the forms which we tell the client or the attender to fill it up. In case if they find it challenging, we help them out to fill it up, to know on the demographic data, on the medical history, what was their earlier pregnancy or miscarriages or anything, whether they had an ART conception or spontaneous conception, whether they're going with the alternative therapies, whether they're going with allopathy therapies, everything is being considered. And the birth experience currently, which position they had adopted, how was the pain, how long they've been going with the labor process, whether they had pain or in the labor process, like they have to be in a lithotomy position for a long time, yes, they may tend to have a greater trochanteric pain post labor. So all the things being monitored, and we give this the chart, pain map chart, where they could color it up and then give it back to us. Based on that, they'll be proceeded further for the interventions. Next one. So this is the assessment form, will be filled by the physio itself for our documentation, which will be pinned up in the case sheet. So once they come back for us to the OPD review, we know what we had done and we know how to proceed them further. That's why we are giving them the home program in that. So when we had mentioned home program, what we had given, why we had given, why we have to make them to see again. So when we see for the postpartum physio assessment, it's not just a musculoskeletal, we tend to check on the respiratory rate, how the skin coloration appears, bladder, whether they had earlier issues or the time of pregnancy it got aggravated, those issues we need to ask. And the voiding pattern, some girls after delivery, as I already said, they will not void so frequently. They may have pain while voiding. And in case if there's a labial tear, that is in the tear during the birth, if it goes near to the bladder side, it may tend to have a burning or irritating sensation, depends upon the grades of tear they're going through. Lochia, the bleeding, the after delivery, how far they're bleeding, whether it's spotting or excessive bleeding. So physio visits makes a mark, because when they see this, they do inform the gynec team that there's excessive bleeding, or when there's no bleeding at all, it gives us a hint on what's a HB level into. So we have to consider to see the HB level also. And the episiotomy site, yes, how's the episiotomy site? How far is the tear has gone? How far they have given the stitches? In case if they've gone with a vacuum, of course, the episiotomy tear and the stitches will be still more bigger. And how it appears, whether it's healing or what. And diastasis recti, we tend to see it, but we generally think that earlier we diagnose it seems to be like more compared to the later days, but we keep them heads up on telling them that you need to have a track onto it, and how you have to bring back your abdominal muscles to a proper shape. At the same time, the stabilization and coordination and balance need to be maintained, and what intervention is being done on that day, and home program is being planned and discussed and being followed up for the next couple of weeks. We tend to follow with this client. Yeah, next one. So when we talk about everything, we have to consider about differential diagnosis. So when you talk about differential diagnosis, it generally divides into three: one, neurological, cardiovascular, and visual. So when we say of neurological one, it can be like slurred speech, or they have a blurred vision, or sometimes they have a severe headache, or if fever is gone beyond 100 or 38 degrees Celsius. So that's a sign that we have to keep the gynec team alarmed, or they have to come and check this is what is happening. In case of cardiovascular issues, check with the BP. If the mother is saying of severe chest pain, tachycardia, orthopnea, dyspnea, or edema, vascular changes, everything we have to check. And visceral is something very kind of overlapping with the musculoskeletal pain. So we have to be very careful when we are doing this diagnosis for musculoskeletal. Sometimes visceral pain, we shouldn't like just can't regret and just move ahead thinking to be a musculoskeletal. So if they have acute abdominal pain, like if they have a radiating suprapubic pain with fever, or they have a shoulder pain with abdominal pain, there's a urinary frequency, urgency, or hematuria, dysuria, they have symptoms of infection, abdominal distension, or pain that limits weight bearing or function of limb, yes, please consider it to be as one of the aspects for differential diagnosis. So as per when you go with differential diagnosis, there are two categories which we divide as to be as visceral organs issues, or with musculoskeletal issues. So coming from the head and neck, it can be of a cluster headache. If it's of a visceral issues, it can be a brain tumor, spinal tumor, vestibular, sinusitis, or in that case of head and neck, when we think of musculoskeletal issues, it can be of a postural dysfunction, it can be a facet joint involvement, or thoracic outlet syndrome. For a shoulder side, we can think on deep vein thrombosis for visceral issues, or they had a kind of rotator cuff lesions. When it comes to musculoskeletal, it can be of a traumatic instability or peripheral nerve injuries, or sometimes even carpal tunnel syndrome should be considered. Coming for the chest wall, thoracic spine, and rib cage, most common visceral issues will be like cardiac events, or pericarditis, or any embolism, pulmonary embolism, asthma, air embolism, pneumonia, or breast cancer, herpes zoster, or any kind of vertebral body fractures, spinal tumors. And when we come for musculoskeletal thing, we think on soft tissue injuries, soft tissue dysfunction, or costochondritis, muscular tenderness, cervical angina, or slipped rib. Anything can come for the musculoskeletal one. For abdomen, the visceral differential diagnosis comes like cholecystitis, pancreatitis, uterine fibroids, appendicitis, or some inflammatory bowel disease, or urinary tract infections. And for the musculoskeletal one, we think on diastasis recti abdominis, or round ligament pain, or pelvic floor dysfunction. Okay. Likewise, lumbar spine. So lumbar spine, we always think on ankylosing spondylitis for the visceral functions, or any spinal infection, sacroiliitis, vertebral body fracture, or pregnancy body induced osteoporosis, which is being actually not seen so carefully. Please have a look when you see a pregnant woman, whether they have been into pregnancy related spine osteoporosis, spinal cord or cauda equina compression. So coming for this musculoskeletal side diagnosis, it can be a pelvic girdle pain or soft tissue injury or benign lumbar generated lower back pain. So coming to hip and thigh, it can be avascular necrosis, hip fracture, synovitis, or melalgia paresthetica, pelvic inflammatory disease, fibromyalgia, and spinal infections, sacroiliitis, deep vein thrombosis. So these things should be considered for the visible organs. And for the musculoskeletal thing, it can be osteoarthritis, myofascial pain, soft tissue injuries, tendonitis. So last coming with the ankle, foot, it can be leg cramp syndrome, or it can be inflammatory arthritis, gout, osteoarthritis for the visceral organ differential diagnosis. For the musculoskeletal one, it can be ligament tear, meniscal tear, or patellofemoral syndrome, Achilles tendonitis, bursitis, or plantar fasciitis. So it not required that you need to have the list everything ready, but when they tend to say to it, it's better to check on your list so that you know where you miss out anything or you need to rule out something. Yes, next one. So coming for the obstetric injuries. Obstetric injuries are actually seems to be considered very carefully when you see a mother. So the obstetric injury is coming from the perineal tear. So perineal tear, you have degrees of tear like first degree, second degree, third degree tear to fourth degree tear. So when you consider with these tears, the postpartum recovery also will be like can be the urinary issues or with the bladder issues, with the anal fissures or the constipation or the incontinence. And going with this perineal trauma, it can be your tear sites can affect your anterior vagina, urethra, clitoris, sometimes the posterior perineal trauma like posterior vaginal wall, perineal muscles, and anal sphincter can be affected. So coming for the laceration repair, sometimes in our patients which we see, there are two groups of patients who take sutures, who doesn't take sutures. So what we find is people who are taking sutures seems to be recovering better compared with people who doesn't take sutures. But post suturing, yes, they do have challenges of sexual pain, dyspnea at the time of sexual intercourse. Then they have kind of a kind of a discomfort of a lump or rashes, or sometimes they tend to have itchiness. So these are being seen because of the materials what they use for the suturing. The products may be allergic for the mother, so we have to consider when the mother is saying to be normal or whether she needs to come for a consultation. Sometimes lumbar injuries like a mechanical injury during the birth, like lot of stress on the lumbar spine because of lying down on the back, muscular strain during birth, the positioning during labor, sometimes osteoporotic compression fracture will lead to this kind of lumbar injuries. Sacral injuries is like in case of they have any osteoporotic history, or there's increased lumbar lordosis, excessive weight gain during the third trimester, vaginal birth with a high birth weight newborn, and there's a quick precipitated labor visit, that is like rapid vaginal birth. Sometimes you tend to hear mother delivering in the auto, in the flight or something, it is said to be a precipitated labor. Those things can lead to sacral injuries. Next is coxial injuries. Coxial injuries like extends in childbirth to widen pelvic outlet, actually coccyx. But some positional restrictions could lead to restricting the coccyx movement. That may go with coccydynia post childbirth. So this has to be really seen because this may result in dyspnea or tension myalgia over the pelvic floor muscles. Okay, so coccyx injury has to be ruled out when they say when they have a tailbone pain, and how it should be recovered. It's only the physio has a hand in getting it to be done without any kind of surgical intervention. So your inputs are more important in knowing with the treatment protocol. So going same with pelvic girdle injuries like pubic symphysis, diastasis. The most important predisposing factors for this kind of injury is multiparity, previous pelvic ling injury, or if there's a labor positioning with hyperabduction of hips, or fetal shoulder dystocia, where baby shoulders are quite big, or rapid and forceful descent of fetal head. The fetal head comes out into the anterior pelvic ring in a very forceful way. If they have used a vacuum or they have used epidural, because epidural they tend to push slowly, in that case they need to use instruments to deliver. This will may lead to kind of a pelvic girdle injuries. Then coming for peripheral nerve injuries, it can be like due to epidural anesthesia, there can be lower extremity nerve injuries, or prolonged second stage of labor, or instrumental birth. All these things can lead to kind of a peripheral nerve injuries. It can be of a neuropraxia, axonomatous, or neuromatous. Whatever it is, it needs to be intervened after ruling out all the differential diagnosis by using your desensitization techniques or braces, or giving modification in your activities of daily living. And progressive exercise treatment seems to be really helpful in getting them recovered. Yes, ma'am. Next one. So how to go with the outcome measures when you're seeing with it? So when you see with the outcome measures, we have to first keep in mind on their pain sensitivity, and how is their general disability is taking into action, whether they're able to perform the function properly in considering the pelvic girdle activity, whether it's restricting their daily life activities, whether there's any challenges in doing it so. And of course, they have their own belief and own perception and thoughts in doing it so, which we need to do both ways, like combining examination and well as clinical decision making, along with going with the psychological thought of the patient. We have to get along with it. In that way, we can plan with the outcome measures also. Yes, next one. So when you see with the outcome measures, there are a lot of questionnaires is being validated and reliable questionnaires. According to the symptoms, what we tend to get from the patients, based on that, we have to get along with the questionnaire. It's better to have it in the back that all these questionnaires, the pelvic girdle questionnaire, symphysis pubic dysfunction questionnaire, low back pain questionnaires, and pain disability index, rating index, the functional activity, any challenges are there, fear avoidance belief. So whether they have any challenges in bringing out the questions, what kind of pain, it's each pain has been described in different matters, whether it's a pain, burning, irritating, radiating, whatever this pain is being described, and they have to get along with it. And the Edinburgh postnatal depression scale is something very popularly being done. One of the study which we are done in this Edinburgh postnatal depression scale, surprisingly, most of the women were depressed because of the financial status. So it's not like postnatal depression always related to labor or breastfeeding. Something beyond the medical process also they are getting depressed. So it's better to get all the data so we know where they are having the issues. So it's better to refer them to concerned consultant. So it's better to know our team. When we know our team, we know whom to refer. So it's not only to medical reasons they get into depression. It can be for non-medical reasons. So communication is a major skill in ruling out all these things. Yes, next one. So coming for the IP thing, so generally we see on the any musculoskeletal pain, how's the perineal tear, breathing, episiotomy care, how's the urinary bowel functions, lactation, musculoskeletal pain, and infant care. So we keep this as a checklist in taking care of it. Out of this, if there anything else is being, we are seeing it out, we take it into differential diagnosis, and we tend to alert our other medical fraternity team, so that we come to a team, we know what it is and how to go ahead from the patient care. Yes, next. So immediate postpartum, the incision care, which is C-section can't be done that time immediately. Yes, of course, a vaginal birth, this episiotomy care, or this post-vaginal birth, if they haven't taken suturing also, how they have to take care of their wound is being advised. Then the breathing activities is being taught to the mother, and isometrics, abdominal, pelvic floor, isometric, ankle toe movements, ambulation is taught, and we taught them how to transfer themselves from bed to stand position, from lying down to sitting position, how to keep themselves mobile, and correcting the posture during feeding, which is very, very important because most mothers tend to come to a slouch posture, tend to bend over. Because of that, they tend to lot of musculoskeletal pain, which they don't understand, thinking this is to be common, but it's not common, which can be rectified. Breastfeeding is supposed to be a pain-free period, not to be a painful one. So telling them on how to take care of infant care and how to take care of the body mechanics when they're handling the baby, or household activities are being given as instructions. And pain management in case of modalities, yes, it's been used during the inpatient visit itself. And scar management, we tell them to follow up in the OPD period. So for the vaginal birth, we tend to see after 2 to 3 weeks. For the C-section, 6 to 7 weeks. It depends upon how the healing process happens. We tend to get the consent from the OPGN, and then we take it forward. Next one. So generally for the OP care, the scar management and pelvic floor muscle strengthening, this is for vaginal birth, and for the C-section scar management and the general post-surgical care has been done. So some things which have been common for both the mode of birth is this lactation, pelvic health rehabilitation, musculoskeletal pain handled, and post-stabilization and posture. So these things have been commonly seen for both mode of deliveries. Next one. So once we come with musculoskeletal dysfunction, yes, of course, first thing which we say is the pelvic floor dysfunction. You know the risk factors why they get into dysfunction. And next we tend to see with the diastasis recti. And most of the time, recent years, I need to say last 3 years, because of COVID, a lot of people gone into online and social media. There's a high degree of awareness among diastasis recti. So even first time they wouldn't have seen it so much. Second time they come with so much awareness. Can you just check whether I have a diastasis recti? I'm not sure of it. So most second time mothers seems to be turning out to be positive, but first time mothers are being so cautious nowadays. So thank you to social media and other non-medical professionals who are propagating this kind of awareness. So as physio, our role is very highly key in this handling of diastasis recti. Next.
Okay, and the X-ray மட்டும் எடுத்துட்டு வா next time வரப்போ.
Next time.
Hip dysfunction, causes of hip or buttock pain. So we have to rule out whether it's osteoporosis or labral tear or greater trochanteric pain syndrome, or any kind of muscular strain because of in the lithotomy position, or even in the floor when they're delivering, they'll be in a full squat position, sitting for a longer time. It can be on gluteus medius weakness that may be experienced as back pain. Next one. So we have to rule out with the Grion pain, whether it is a musculoskeletal or nerve entrapment. Every time it can't be only musculoskeletal. So it's better to have a chart ready so that we can just rule out whether which muscle with its sensory or motor has been involved. Based on that, our interventions will be very easier to be handled. So lumbar pelvic pain, the test, so many tests are there. By getting your test positive, you can rule out how you can go ahead with your intervention process. And lateral hip pain will be the greater trochanteric pain, and coccydynia, as I already mentioned, will be one more musculoskeletal pain, or a bony related pain also will be there. Yes, next one. So I was telling about the chart. This is how we keep the chart. So in case of requirement, this comes as a savior for us to rule out which nerve is being injured. Based on that, the treatment protocol goes. Because generally when they come to us, they say ligament pull. It's a muscular strain, I think, because I'm sitting for a long time. This is how they tend to converse. But when we see there'll be a nerve involvement would be there. It can be a neuropathy, or it can be a kind of a sensory one. Most important challenge would be they can't be standing in one leg. they can't lift and bear the pant in one leg. This is an immediate challenge we tend to see 4 weeks or 5 weeks postpartum. So the intervention process for this kind of cases, like going ahead with them for a 3 months, 6 months period, they seem to be completely normal post our interventions. Yes, next one. So yes, gait is important one. The usual optimal gait is you usually know that there should be a neutral pelvis and there should be a slight tilt in the pelvis, and you should have your pubic bone in the same plane with your anterior iliac spine, and not excessive use of your gluteus maximus, erector spinae, rhomboids, abnormal oblique muscle activity and all. But when it connects to your low back pain or pelvic pain, in that case, you can see there's an in-phase pelvic and thorax rotation which occurs, and both at the low and high velocity it happens. So it needs to be seen in the outpatient department. Many times we will not be able to correct during the antenatal period. So postpartum period is a good opportunity for them to correct the posture. In that way, the musculoskeletal pain has been maximum reduced along with the neural utilities. Next one. Yeah, diastasis recti, as I mentioned, there are different stages of it. The measuring, the lot of measurement things are available, but generally what I use is my hands. So that gives me a better cue to understand and make the even the mother and her husband to come and see how they are being gapped, so they can check it on the own at the residence. And we can find there's a difference in the early postpartum and the later postpartum, that diastasis recti, there's a difference in appearance. So if it's required to stimulation is being done, kinesiotaping, yes, it seems to be beneficial. Again, it's not for everyone, depends on case to case, according to their level it's been given. And abnormal bells, until unless there's a severe challenge in the pelvic pubic pain, we don't recommend abdominal bells on a regular basis. If the mother is being able to do the isometrics and she's able to have a exercise pattern and interventions normally, abdominal bells is not being done on a regular basis. Next one. So pelvic floor muscle training, yes, should be started with particular parameters, how like holding time, how we are going to give it, it's a slow or rapid contraction, what is your recovery time between the contraction, how many times they have to repeat, how many sets they have to do. So each program, it should have at least 6 weeks program, then only you can see visible results. So these and all should be like already being prepared mentally to the mother, so that in that case she can see the improvement also. To increase pelvic floor muscle training intensity, you first gradually have to see with the number of contractions and duration of contraction, what they're doing, whether they're doing a fast fit contraction, slow, and using vaginal cones with different weights. This is going with the next level of
YouTube program.
I'm sorry. Yes. So vaginal cones.
Hello, sir. Dr. Subhashree, sir. Sir,
Okay. So vaginal cones with different weights seems to be really beneficial for many women who wants to have an active sexual life and sexual activity. And this has been done with the biofeedback, either with the instrument, but we generally believe with the finger to be a best instrument to analyze and just correct themselves. As of now, we are doing with the fingers itself. The mother herself can do it on her own to analyze how the muscle has been contracting. Next one. And going with the stabilization exercise, neuromuscular control exercise, all our muscle energy techniques. And of course, you are doing a myofascial and manual therapy techniques. Please write it in your documentation what the client have given the consent to move forward. Your exercise progression also has to be on a gradual way, from unloaded to loaded, from low center of gravity to high center of gravity, from low resistance to added resistance. It has to be gradually progressing. Next one. So yes, as for biomechanical strategies, you have to teach them on how to be in the daily life activities, how they have to sleep, how they have to get up, how they have to move on, how they have to get inside the car, come out of the car, carrying, lifting, everything has to be said. And postpartum binders, whether it is required for them, when they should use, in case of a carpal tunnel syndrome, how they can use a wrist splints. Many mothers tend to have a wrist pain or decurrence pain because of holding the baby for long hours. So we have to consider when we are taking the history of the mother, not only the mother's maternal history, we have to check on the infant history. How is the baby doing? Whether the baby is fine, baby is in the NICU, is there any challenges in the lactation, whether she has able to feed a baby, any kind of physical challenges in doing it. So please consider that, because that plays a very important role for them psychologically in getting themselves treated along with you. Next one. So for biomechanics and how to take care of the infant, like dropping, picking up, carrying, all these things has to be given with the visual cues. But it's actually practically very difficult as a mother to follow unless they've been in your loophole on a regular basis. You do some activities on a regular basis that keeps them alarm. Yes, I have to be doing that. Otherwise, it's a general thing like, okay, fine, let me do for now. Let me see it later. So we need to keep following up with it. Yes, next one. Breastfeeding postures, any posture, the back spine has to be erect. There's no best posture as such. Okay, as a human, I can't sit for this long time in one position. I have to keep moving around. I have to get up, I have to turn. So that's how a breastfeeding mother also is supposed to be. So basically, we see to the latching. This is a very big subject. I don't want to go deep into it, but basically, if the baby's latch and withdrawal is good, we are okay with any position. So a mother should be taught with different positions so that she can maintain her posture, so she doesn't land up with any kind of pain or any kind of, sometimes because of continuous sitting, they tend to have toxic pain also. So all these things should be considered when you're talking with the mother. Next. So postpartum sexual health, which is actually no one comes and says, I have an issue in my sexual health in OPD. But when we tend to see them for other issues, we tend to have a conversation like that, and then we pick it up. Most of our, I'm practicing in urban sector, mostly middle class population. So most of them are like, I done it maybe a year before, or we are very scared to do it. We don't know whether we can do it. We are not sure whether we can do it. So it's as Dr. Subhashree said, we tend to talk anything to a friend, a sister, or family members, but we never tend to open up. Kind of a taboo is there always in front of us. And by talking this, we can't judge a person. It's not like when someone talks like, we can't say the person is like this or person is not like that. So I always believe opening up the conversation is important, and it not required to be only for women. Whenever I do conversation, anything, I keep the partners along with them. I open the conversation from the men. So they tend to open up, and then they say, yes, she has challenges. She says she's having a pain when I'm doing so. She's not interested. She is having a lot of commitment. So this conversation only will happen once they see them for a longer period. So one fine day when they come for the OPD, they again, unless they have a very bad pain, they don't come. So we have to have the conversation on a regular basis. So they tend to open up this kind of topic, whether they're using a contraceptives or not. Sometimes you go with the natural lactational amenorrhea, we say, but it's not 100% safe, because many mothers during the breastfeeding period, by 6 months itself, they'll be 4 months pregnant. They don't know that they're pregnant also. So please have a conversation when they are coming for you. Screening tools are there. Please consider for screening tools if they tend to say they have challenges in their sexual activity. Next one. So obstetric scars and insertion, yes, you need to start with evaluation, mobilization. Everything has to be done after it's been healed only. Please get the consent from the OBGYN, and then you can start. And please consider the contraindication before touching any wound. Next one. So modalities are usual physio modalities as being used in various subjects other than the musculoskeletal pain, like perineal pain. Yes, it gives really good relief. Breast engorgement, it reduces. We can immediately latch the baby able to suckle really well. In a blocked duct or with kind of pain in the nipple region where there's a blocked duct is there, it seems to be really relieving. So please consider all these modalities other than the musculoskeletal pain. And we tend to have started IRR immediately after vaginal birth mothers, like for healing of the perineal area. That also seems to be really rewarding for us in getting the feedback from the mothers. Yes, next one. So it is a general contraindication while using the modalities. Please consider before using it. Next one. So postpartum exercise, as already said, please consider the previous exercise, how they have been done, whether they want to go for the fitness level or whether they want to regain the core stabilization. Consider that you have to go with your postpartum period exercise prescription. Next one. Hydrotherapy, this is really a fun way of doing it, but only challenge in the postnatal care is there will be very high dropout in this because the time commitment with the infant care, it's not so easy for a mother to come. As with online, many of them are able to do with postnatal, but having a direct hydrotherapy, we find it very challenging, but it's really good. They feel really relaxed, but make sure they don't have low BP, they shouldn't get dehydrated, and whether they have open wounds or whether they are bleeding, these things are all considered before telling them to go with the hydrotherapy. Next one. So postpartum physio, it's not just the general public whom we are seeing. The high skilled workers in this is seeing a high risk pregnancy mothers, traumatic injuries. If there's any psychological issue, neurological issues, adolescent mothers, if the mother has any physical challenges or special mothers, this where a physiotherapist comes a major role in intervening in giving them the best possible way in infant care, as well as the mother's daily life activities also shouldn't be interrupted. Next one. So these are the perineal scar, how it can be taught, and this is one for the C-section scar management. Next one. For rectus abdominal stimulation, this can be done. Next. So this is a general form. We tend to do it in the prenatal period, prenatal breast assessment form. Next one. And after delivery in the inpatient wards, we do this latch assessment to see how the mother is handling, whether she's handling good or not. In case if her score comes below 7, that means she's not so confident in doing a breastfeeding practice. That indicates that she has to come back for a review doing the correction. Many of the hospitals have included this as one of the checklist in the discharge summary. Next one. So this is a mother self breastfeeding assessment form. We tend to give them to know whether baby is urinating well or baby sleepy, drowsy, not feeding. So if any of these things are coming out to be ticked, that means you have to come and contact us. And you can see there's a breastfeeding support group also. We have this support group 24/7, helping each other from mother to mother. And as experts, we also monitor whether the conversations are going right. So in that way, we are able to maintain our breastfeeding practice success to 80 to 85%. Next one. So we do monthly audits of our postpartum physio, like how many people had a complaint, how many had a treatment, whether they found it out to be useful, the perineal care, they had a follow-up, whether they had a complaints, then a lactation follow-up, only percent of exclusive breastfeeding rates. And we have pelvic rehab sessions. They should be enrolling by 7 weeks or 8 weeks post childbirth. So how many have enrolled, and in that the feedback, in that we teach them on vaginal toning. So we do have support groups, and later on they'll be slowly switched over to the fitness group. So later period they'll be shifted to the developmental milestone therapist. So this is how a postpartum physio can literally grow. It's not just restricted inside the IP room, just showing the ankle toe movements alone. It's just getting bigger and bigger. Our opportunities also is getting bigger. Next one. So I'm just showing a sample of our audit, what we had in one of our center. We do collaborate with multiple centers in Chennai. In one of the centers, they had this many normal C-section, natural birth. VBAC is vaginal birth after cesarean. Next one. So in that, how many had complaints and how many had treatment later on? Next one. So what kind of modality they had, how they felt it. We usually collect the feedback forms also, whether they are finding it relieving or they have to come back to us in the OPD. Next one. So time of discharge, the LAT score, which I showed. How was the LAT score at in the inpatient ward, and at the time of discharge, we see the LAT score. Next. And we have a charts on in a month, how many babies are in direct breastfeeding, how many are in express breast milk, how many are formula feeds, and how we are going to follow up after 6 weeks, whether they're going to shift or whether they're going to give an informed decision on going ahead with the mixed feeds. Next one. So we do follow-up calls on a regular basis on all these categories. We tend to do a follow-up calls. Next. So this is one of a mother who had a natural birth. Can you see she's delivering on a husband's lap? So this is how it would be. So anyone considering, please consider natural birthing. It's so much joy inside the womb. That's her mother, her husband. There's so much happiness inside the room. Next one. So for a C-section mother, we teach the partner and how to handle the baby and how to help the mother. It's not the grannies being taught. It's mostly men are being actively involved in the postpartum care. Next one. So this is our team. We appreciate each and everyone in our team. That's a green sari Emma who helps in cleaning up activities, our staff nurse, our TMO, our OBGM, and our birth support person, the mother's partner, spouse. So everyone has an equal share in having a successful pregnancy, birthing, and postpartum care. Until unless we don't share the success, the ultimate success is not being tasted by an individual. Yes, next one. Next. Next one. These are the activities we tend to do during the prenatal period. See, all the things will come only when there's a long-term connectivity. So once that's been there, they tend to get connected even in the postpartum period. So everything has to begin with the antenatal period. Next one. So we do have our support groups. This is how we stick it all over the hospital so that they could contact us and then do get maximum help from us. Next one. So this is, we had it last year, like triplets who've been exclusive breastfeeding. They've been 28 weeks preterms who've been in NICU, but still the mother being able to do exclusive breastfeeding. It's completely a team approach. The success has been a team approach for us where we still celebrate. We are looking for the 1 year birthday celebration of this babies also. Next one. So these mothers, this one is like 6-month-old who's standing here. She went for a trekking to Goa. So by 3rd month, she joined the pelvic rehab sessions. She was completely back to her fitness level. And I said, you can join any kind of fitness regime you want to. And the other one who wants to do public breastfeeding. So as a therapist, we need to show them a comfortable position where they could make the posture erect and proper, where they are comfortable in feeding. So she sent her the pic, how comfortable she's doing a public breastfeeding outside. Next one. So this is a pic of one of our mother. That's first one. She immediately after delivery, she took it. 1 year later, the same dress, same costume, only the baby is 1 year old. So this sharing of joy continues for a year period. So it's not like I'm done in the hospital or IP or OP. They're just getting continued. I know it takes our time or energy, but the amount of love they show to us, it's enormous. Next one. So we had a natural birthing. This is another hospital, which we had it in 2020. So there's a lot of celebration in the hospital when we had it first time. Next one. So you need to know about the Lakshya guidelines. Please go through the guidelines. People who are working in the maternity homes, you need to know the guidelines because that covers the patient rights also. And as a respectful maternity care, Lakshya guidelines have been announced. All government hospitals are following it. Please go through that. Next one. And I know we have been into now National Commission for Allied Healthcare Professional Act, and even lactation consultant has come to this act. That's why from 2021, I stopped using the term lactation consultant. Instead, I started using, I've been certified in that. So this becomes as an add-on skill, but not as a separate qualification. For that, this act has come to scrutinize. So it's not like everyone can use that term. Only people who have done 2000 hours in India, qualified and certified like a physiotherapist, they can use it. So you need to be aware about all these rules and laws because legality is getting highly seen nowadays. Anyone can get into legal scrutiny. Next one. So these are the non-medical people who have joined together. They started to raise voice as a voice for women. They wanted to talk for women. Many activities are being done because it's not being initiated from the medical fraternity, they feel. So I feel from our side, if we are doing an extensive work, I think we can get along as a team from the medical person as well as a layman, both together. The success is enormous. Next one. So as from Happy Mom from my side, because of all the things which we have seen, we've been doing a lot of activities. Last 3 years, this is the 4th year, we are going to come up with clinical updates in Indian breastfeeding practice. Please keep a watch on to it, which will keep you updated on the clinical practice. And we had collaborated with many hospitals and we are looking out for associates who want to associate with them to grow individually in career and for them to flourish in their career also. And we are coming up with a lactation skill training program, and we do have labor therapists who've been specifically been available during the labor time. In maternity units, it's a high demand for everyone to get a labor assistance to be there round the clock. Next one. So physio and maternity is high in demand. Actually speaking, you need a physio as a team 24/7 because compared to the antenatal, labor, postpartum, so 24/7, if you have a coverage only, you get that kind of service to the mother. And need to be a team of physio, which I learned single physio can't do it. So I'm building up with the team and finding it really rewarding by the kind of response from my clients which they give it. They say as your team is doing amazing. So that is something very nice to hear. So always share appreciation and critics. So every appreciation will remind us that where we are standing, that critics will show us where we have to go. So don't go down easily. At the same time, don't go high. So everything will keep us matured and see us better for the future. Try to explore new horizon. Don't get restricted with the normal, usual, regular one. Try to question yourself. Try to move forward. In that way, our portfolio on practicing in maternity field goes bigger. And as I already said, there's a requirement, and try to have a reaching common man. That is the social medias and everything, reaching to the common topics that stay connected with us still more closer. Communication is the major skill. Speaking to your heart is the one which you can get people towards you. So be truthful to yourself and to the clients, be evidence-based, and get along with the other medical fraternity team, and appreciation should be shared with them. It's not because of me it happened, it's because of my team it happened. So that will go to the growth of it. There'll be a lot of hurdles and challenges. It's not been welcomed all the time. But as a team, when you start to see, they understand that what you're doing is for the team, not for an individual progress. They'll understand. Be ethical and truthful to your practice. The professionalism will always give you rewards. Next. These are my references. Next one. Thank you. Thank you for listening patiently. I think I've covered my whole 1 hour.
It was actually a very good presentation, ma'am. Seriously, a very useful one for all the therapists. Really, I think nobody will be getting any doubts because it was very clear, slide by slide. It was very clear actually. Participants, any questions? You can use the chat box. Participants? I think it was very clear for everyone.
It's a both way I have to take. Either it is clear, otherwise too bored. Both ways
But
I take.
according to my opinion, like slide by slide, it was explaining each and everything. If we get some questions also, we can get the answers in the next slide. It was very clear.
நீங்க
It
டிப்ஸ்
was
எல்லாம்
actually
கூட்டு போயிடுங்கப்பா, கிளம்புங்க, கூட்டு போயிடுங்க. அங்க ஆனந்த் சார், ஹேமா மேம்னு ஒருத்தருக்கு லெட்டர் எழுதியிருக்கேன். அவங்க போனோன்னு பாத்துருவாங்க. பார்த்துட்டு ட்ரிப்ஸ் ஆரம்பிக்கிட்டோம், ஸ்டேபிள் ஆகட்டும். சண்டே நான் வரேன். நல்லா இருந்தாங்கன்னா சண்டே பண்ணிக்கலாம். இல்ல
okay. Dr. Sindhuja ma'am, you just please take over for your vote of thanks. Just a minute, ma'am. Ma'am, Jaishree ma'am, you have any other things to share, like in common, or
Yes,
any advice for the budding physios?
Yes, please. There's a lot of high opportunities are there. I feel I'm thankful to knowing your team. Even from today, I was like asking Janine, is there any physios are there? I need a high demand. Is there? Please refer, so that it's there. All maternity homes need 24/7 physios, and for them, they don't know how to use them. So when I'm giving them the exact plan and how these physios will be acting, no, they find half of the things is done. So my physio will take the role in taking care of your pregnancy doubts, labor time, and post-delivery. And we are giving the extensive support of these kind of support groups and all. So something, when you keep doing one thing or the other, they start to pick it up. And I'm coming up with a lot of workshops and conferences. Please do join. And
You can post your website in the chat box so that it will be
it's
helpful.
happymom.in. Happymom.in, which will be like going for some more relevant things in that website. So mostly by June, we come up with some more plans in that.
That's so nice, ma'am. Thanks to have you here, actually.
Yeah, thank you to the IAP team only, I have to say.
Jaishree ma'am, it was a very nice.
I'm sorry, Dr. Sindhuja, I can't hear you.
You're not audible, ma'am, Dr. Sindhuja ma'am. There's some network issue. Can you hear us, Dr. Sindhuja ma'am?
Divya, can you hear me?
No, your voice is very low, actually, very feeble.
No, ma'am.
Okay. Actually, Dr. Jaishree ma'am, like many physios, they still have some doubts. Like, I'm not a qualified, I've not done my master's in obstetrics or gynecology, but how far I can proceed with that department without any experience or like that. Many physios have that problem, but I think this industry is blooming actually. Role of physiotherapy in maternity and obstetrics, like it is blooming now, right?
Yes, see, myself, I'm not a master's. I haven't done my master's. After finishing my bachelor's, I was a girl, like want to explore. So I was keep on exploring. Still, I was not reaching my satisfaction level. So once I got to the gynec field, I started to look out from the client base. See, when you be as a physio, everything will be like test. Musculoskeletal motions, range of motion, what is the challenge? It will be like that. But once I tend to see from a mother's side what she is looking for, she's looking for peacefulness, calmness, something very comforting, everything to be positive. So we have to change the way of practice by seeing from their side and approach from her physiotherapy side and how to get it along with them as a team. So this is been evolving. It's every time we do, okay, let's try this, let's try this. That's how we have come to this level. It's not like this all we had planned it earlier and we did it. No, not at all. Every time we do one at a time. Even now we have started something called infant tactile stimulation therapy. So why we started this, we find mothers are getting jittery in handling the baby. So we thought we'll teach them on how to do tactile stimulation. That's what the infant massage, so that they get to know to do it at home. They can do by themselves. They get bonded with the baby. So these small things is still opportunities under the physio section, which as a physio, we ourselves don't know that we can do it. So I have to give some terms for it. So which as a layman, they understand there's something in that. At the same time, they know this is being done by a specified consultant. I've been sometimes questioned, you are a physio, how come you're doing for pregnancy and labor? You're there for a labor, you're physio, how you are there for labor? So I have to again say, what is the curriculum, how we go through. So everyone's idea is physio is for orthopedic and neuro. They are the ones who have taken it. But it's actually being there for OBG for a bigger aspect. Many OBGYNs find so relief when they have a dedicated physio along with their team, because most of their questions are being answered and handled by the physio. Much of the consultation time is being getting reduced and more of teamwork also gets built up. And you can see the same person or the same team during the birthing and post-delivery, the connectivity grows. So it's not like I'm seeing the mother for the first childbirth. I'm seeing her for the second one. I'm seeing her sister. I'm seeing her cousin. I'm seeing her friend. So they all come in a circle like, okay, go to the ma'am. She'll go with birthing. It's not, I don't tell, come, I'll promise you for vaginal birth. No, not like that. You know about the process, you know how to take it, you have to get along the team. That is birthing team as well as a family, their family. It's not husband and wife alone. It's a husband, wife, their mother, mother-in-law, because we are in a system with a group family. It's not we are individual, like me and my husband will take a call. That's actually, it's not always possible in our system. So when we both together be truthful and talk everything, yes, the results are like, when they write testimonials, no, they write even the IMR's name, staff nurse name, even the person who came to help, the receptionist, everyone that actually so happy to see that. They're able to recognize each and everyone. So it shouldn't be like, because of the physio it happened. Because of the team it should be happen. So always try to appreciate the other works. And yes, critics' complaints will make us to groom still more better. There were days I was so broken when I saw my first negative thing, but later on I started, okay, why it happened, how to avoid it, how to make it better. So that's the way we can groom better.
Thank you so much, ma'am. Dr. Sindhuja, ma'am?
Yes, ma'am.
Yes, are you ready for the order science?
Yeah, ma'am, I'm ready.
Yeah. Can you be still louder?
Yes, ma'am. And the IIT Universal National Lucy ma'am, and the zonal head Dr. Prabha ma'am, and our state coordinator Dr. Janani ma'am, and my sub-coordinators of the Cervical team, and my sub-coordinators of the Cervical team, Vanilla and Deepa ma'am. So I would express my gratitude to Honorable Subhashree and the Jaishree ma'am to take out time webinar.
Thank you, Dr. Sindhuja ma'am. Actually, it was a great event by the newly formed Chengalpet district team. So we are expecting much more events from your side. Thanks a lot, Jaishree ma'am. Thanks a lot, and Dr. Subhashree ma'am. It was really a great.
Thank you so much.
Thanks a lot. Let's be in touch for further events to happen in IIT. Thank you, IIT. Thank you, Dr. Vanilla. Thank you, Dr. Deepa. Thanks a lot for Janani ma'am and South Zonal Head, Dr. Mercy Jayprabha ma'am. Thanks a lot for being in the event.
Yeah, thank you, team. Thank you so much for this invite.
It's a pleasure, ma'am. Happy to meet you again.
Yeah, happy to
Thank you,
meet you
ma'am.
all.
Thank you so much.
Looking forward to meet you all.
Okay.
You
Let's
can
wind
finish.
up the session.
Yes.
Session, ma'am. Thank you.
Thank you.
Thank you, everyone.